Hey guys, Dr. Tristan here. I'm doing my first live, so I hope that you will enjoy it. Thank you so much once again. The response, the support, everything has just been overwhelming. I'm blown away. You guys are amazing. And a shout out to my listeners and subscribers in India, in Mexico, in Russia. It's crazy. So firstly, Dr. Tristan Anesthesia Tutorials is everywhere. Like, share, and subscribe. YouTube, Facebook, Instagram, Reels, X, TikTok, Spotify, Apple Podcasts, wherever you get your podcasts. I'm now active on PayPal, and we are going to be launching the subscription models from the 1st of August, so please stay tuned. My email address is drtristan@Anesthesia Tutorials. Remember, I'm South African, so it is the British spelling, ANAES. So it's drtristan@anesthesiatutorials.co.za. Please send any questions you have there, and you will be also made part of my mailing list. So guys, what I decided to do now for this live, I was going to chat to you about that case. Or the two cases, the two unfortunate deaths on table, the only two deaths on table I've ever had in my career, thank God, of children. So the first one was I forget the age, youngish child, 4, 5, 6, and he had a dilated cardiomyopathy, and we weren't sure what the cause was. We thought most likely, or the peds cardiologists thought most likely, that it was due to a congenital cardiomyopathy, so an inherited disorder, whereby you get, there's a few of them. The ones we often know is a hypertrophic cardiomyopathy, where the left ventricle becomes very, very, very hypertrophic, and you get what's called a HOCM, so hypertrophic obstructive cardiomyopathy, where that thick interventricular septum starts to impede on the left ventricular outflow tract. This child didn't have that. As I said, he had a dilated cardiomyopathy, but not bad. His ejection fraction was above 50%, which is really not bad at all. So the suspicion here was that he had a congenital or a genetic dilated cardiomyopathy. So he was coming for a diagnostic cath. What happened was, I am a huge fan of eye gels, and we induced the kid in my way that I. Okay, guys, I'm back. Sorry about that. Just want you to say hello to Machubaka. Say hello to all the people, my love. Hey, Machusibucks. All right, guys. So I'm actually going to talk about a different story now. Sorry. We're going to talk about that unrepaired Tetralogy of Fallot. He was about an 8 or a 10-year-old boy. And he came in with all the features of acute appendicitis. So the surgeons obviously saw that I was on call, and they were like, well, thank goodness. And we decided that we were going to take him to theatre and obviously see what we can do. So on examination, he had digital clubbing. He had cyanosis. He had a tachycardia, and he had all of the classic features. So remember, we ran through them. So the features of a tetralogy of Fallot, the four pathognomonic features, is it's an cyanotic right to left shunt with a VSD, right ventricular hypertrophy, and obstruction to the right ventricular outflow tract, most commonly in the form of infundibular stenosis, but it can be pulmonic valve stenosis. So I did an ECG, basically just showed right ventricular hypertrophy with a right axis deviation and a bit of a strain pattern. Echo showed, as we said, an unrepaired VSD with pulmonary hypertension. Not pulmonary hypertension, excuse me, with right ventricular hypertension, and with a significant right to left shunt. And he had about a 60% infundibular stenosis. So I obviously put up a drip for him, brought him to theatre. We did bloods and everything, HB, besides his septic markers, and he was a bit acidotic, nothing that's going to sort of blow your mind. So what did we do then, guys? Well, I brought him to theatre. He had an IV line, and I followed my rules, okay? Now, just because it's not Cath lab doesn't mean you don't follow Dr. Tristan's rules. I asked my 10 questions, okay? So what is the lesion? Where is blood going? What are they doing here? So this was non-cardiac related, and they were going to do an appendicectomy. They wanted to do it laparoscopically, and that's something that we're going to talk about in our next live, is laparoscopic surgery in the congenital cardiac, specifically talking about whether they've got BT shunts, whether they've got a Fontan circulation, etc., or any sort of single ventricle circulation. But put up an IV line. I gave him a 30 ml per kilo fluid bolus, and his SATs immediately went from 68 to 74%. His heart rate slowed a bit, okay? And then I used my trusty ketofol. So how do I mix it, guys? So in a 20 ml syringe, I take 50 milligrams of propofol and 200 milligrams of ketamine. So that is a 4-to-1 ratio of my ketofol. So 4 milligrams of ketamine for every 1 milligram of propofol. My Chewbacca, relax, my boy. Let me just open the window for you. Okay. Sorry, he's moaning because he wants to look out at the window. So I used I gave that in a dose of 1 ml per kilogram with some oxygen, 2.5% sevoflurane, and I then also gave rocuronium, tubed him. I put him on very, very gentle pressure control ventilation with a delta P of 6. So he had a PEEP of 6 and a PRP of 12. And I kept him on an increased FiO2. Hello. I'm just paying for my breakfast. Sorry, I'm on TikTok. Yes. Thanks so much. Thank you. So I gave him the fluids, ketofol. Thank you, you too. I gave him a nice big dose of analgesia, 2 to 3 marks per kg of fentanyl to blunt any stress response. We then settled him, and they started the surgery after I'd put in my A-line and my CVP. Unfortunately, at Barra, we didn't have a transesophageal echo probe, which would have been my absolute first prize. What did I do then, guys? Well, I gave a big dose of morphine, perfalgan, decadron, anti-inflammatory, the works. They opened, and we did a gentle insufflation to about 8 centimeters of water, and his pressures didn't really budge. They went up slightly to 10, and he was roughly okay. His SATs were about 64, 65, sometimes below 55%. He had one TET spell during the procedure, and that was when they were manipulating quite a lot to get to the appendix, which was quite far away from deep down in the pelvis. And I applied my TET strategy. So the surgeon compressed the femorals, 100% FiO2. I gave him a nice big dose. I gave him 10 micrograms per kilogram of phenol, and fluid bolus and a little bit of bicarb and a 1 milligram per kilogram bolus of esmolol, and it worked beautifully, and he recovered. SATs dropped down to 38%, but no bradycardia. And that's the last tip I wanted to leave with you guys here. I extubated the child. He went to ICU. He did very well, and he was then referred to the Cath lab team to renew his follow-up and to be investigated for cardiac surgery. So guys, the trick with them is treat them like you would in Cath lab. So keep it low, keep it slow, make sure that they're well analgesed and that you have a plan to treat any TET spells. And hopefully after you've heard this and watched this story, you will be confident and able to do an unrepaired Tetralogy of Fallot with some help. Call me, call a friend, call a cardiac anesthetist, but it certainly is not difficult, guys. It's not something that you should be afraid of. And I am so, I'm really so stoked that at the feedback and everything that I've received, guys. So keep watching, keep liking, keep subscribing. Dr. Tristan Anesthesia Tutorials is going to be in China and India soon. Watch this space. Thank you.